welcome. This is Dr. Rifat Faruqi. In this video, I'm going to cover beta adrenergic receptor blocking agents. And lipid chart you can see. Remember these 2 points related to the beta blockers. Number 1, beta blockers are the competitive antagonists. They compete with endogenous catecholamines for binding to adrenergic beta receptors. Beta blockers may be non-selective or beta 1 selective agents. Beta non-selective agents are those that block both beta 1 and beta 2 receptors, while beta 1 selective are those that are only they only have affinity for beta 1 receptors and selectively block the beta 1 receptor which is present in heart. So these beta 1 selective are also called cardioselective agents. And here you can see these beta blockers, they do not induce postural hypertension. Why? Because they don't have effect on alpha receptors which are present on the peripheral vasculature. And this actually is a feature. Postural hypertension is a feature of alpha blocking agents, right? So these beta blockers, they do not induce postural hypertension as the alpha receptors are remain functional. And you can see over here there are several clinical indications of beta blockers. They are all used in almost all cardiovascular diseases, including hypertension, angina, myocardial infarction, arrhythmias, and the cardiac congestive heart failure. It is also used in hyperthyroidism and glaucoma. Just remember, you need to remember what is the role of beta blockers in these conditions, just for your knowledge, maybe for BCQ point of view. In this slide, just go through the members of beta non-selective and beta 1 selective. Remember all the names of beta non-selective and beta 1 selective. They are very important. Okay, in next slide you can see beta blockers with sympathomimetic activity. Like we have beta blockers which also acting as partial agonist. Like they can activate beta receptors. So they have intrinsic, some beta blockers do have intrinsic sympathomimetic activity because they are acting as partial agonist at beta receptors. So you should remember the example of these drugs. Now generally, what is the mechanism of action of beta blockers? You just need to remember these drugs occupy beta receptors. They competitively inhibit the receptor occupancy by the endogenous catecholamines or other beta agonist. So these drugs actually block the actions of epinephrine or other beta receptor agonist on beta receptors. So it blocks the beta agonist or the catecholamine action, is particularly the epinephrine on beta receptors. Here in lipin you can see they have given the details of propranolol. Propranolol is a prototype of beta blocking agent. It should be on your fingertip. Each and everything that is related to the propranolol you should remember, you should memorize. So it is a prototype drug, that means it is a main member of the beta blocking class agents. Okay, here you can see the effects of propranolol. So top at the top you should remember the propranolol action on cardiovascular system. It has negative inotropic and chronotropic effect. It has negative dromotropic effect. It directly depresses SA and AV node activity. So it decreases the heart rate, it decreases the contractility, it decreases the conduction velocity at SA node and AV node. Here you can see the role of beta blockers in patients with angina. Why beta blocking drugs are given in patients with angina? Because it decreases the workload, it decreases the oxygen consumption by decreasing the heart rate and decreasing the contractility of the heart. Therefore, they are indicated in patients with angina. And here you can see why it is important in patients with arrhythmias, abnormal rhythm of the heart. And beta blocking agents are particularly effective in supraventricular cardiac arrhythmias that originates above the ventricles. Here you can see it has direct effect on it directly depresses the SA node and AV nodal conduction. Therefore, it is particularly important in patients with supraventricular arrhythmias. Okay, these beta blocking agents, they also induces peripheral vasoconstriction. How they produces? They don't have effect on alpha receptors, but they do have effect, especially particularly the non-selective beta blocking agents. They do block beta 2 receptors in skeletal muscles, so they reverses the vasodilation, that is beta 2 receptor induced vasodilation, thereby they produces peripheral vasoconstriction. Beta 2 receptors in bronchi are responsible for the bronchodilation. If you give non-selective beta blocking agents, and they will going to block beta 2 receptors in the respiratory tract and can cause bronchoconstriction. So these drugs, non-selective beta blocking agents, should be avoided in patients with asthma or chronic obstructive pulmonary disease, COPD. They should be these drugs, non-selective propranolol. It is contraindicated in these conditions, COPD and asthma. In patients with COPD and asthma, we usually give beta 1 selective agents who do not block beta 2 receptors and respiratory tract. Okay, in this slide you can see the pharmacological effects of propranolol. Okay, the acute effects, if you can see the acute effects increase, initially it can increase the blood pressure due to unopposed alpha 1 induced vasoconstriction and beta 2 induced vasoconstriction. That's why initially it can increase the blood pressure. But with chronic or long-term administration of beta blocking agents will going to decrease blood pressure. One mechanism of blood pressure lowering mechanism of beta blocker is by decreasing the cardiac output and decreasing the blood pressure. The other mechanism of decreasing the blood pressure by the beta blockers is inhibition of the release of renin. Usually beta receptor stimulation in the kidney will causes renin release, and if you block the beta receptor, then this will going to decrease the renin release, thereby decreasing the blood pressure. Beta blockers reduces the intraocular pressure by decreasing the aqueous humor production. Therefore, these drugs can be used in patients with glaucoma. Chronic use of beta blockers can cause hypercholesterolemia. How? As when beta 2 receptor is stimulated, it will going to increase the activity of lipase, which is responsible for the lipolysis of triglycerides and the bad cholesterol. So if beta blocking agent is giving, this will going to decrease the lipolysis and increases the LDL cholesterol, that is bad cholesterol, and increases the triglyceride level and decreases the good cholesterol level, that is HDL. Beta receptor stimulation in pancreas is responsible for the release of glucagon, and if you give beta blocking drugs, this will going to affect the glucose metabolism. It will going to affect glucose metabolism. As you know, glucagon is released upon stimulation of beta receptors, and if you block the beta receptors, then this will going to decrease the glucagon release from the pancreas and also decrease the gluconeogenesis in the liver. So ultimately it will going to reduce the sugar level. This is important if propranolol is given to a diabetic patient receiving insulin. Careful monitoring of blood glucose is essential. Insulin is also going to reduce the blood sugar level. Therefore, careful monitoring is required if the patient is also receiving insulin and patient is going to receive propranolol and is already on insulin therapy. So the close monitoring of blood glucose is required in these patients. You can also go through this blocked action of isoproterenol. Just remember, isoproterenol is a beta non-selective agonist, and if in presence of beta blocker, if you give isoproterenol, then it will not going to stimulate beta 1 and beta 2 receptors, so it does not cause cardiac stimulation in presence of beta blocking agents. So these are the therapeutic uses of uh, the propranolol or the beta blocking agents. Just go through it. Okay, do you need to memorize why propranolol is indicated in hypertension, as it reduces the cardiac output, decreases the blood pressure. Why it is indicated in angina pectoris, it reduces the workload on angina by decreasing the heart rate, decreasing the contractility, and it also decreases the oxygen consumption by decreasing the contractility and the heart rate. So why one of the indication is supraventricular arrhythmia, so you should also mention it over here. But we give other beta blocking agents in patients with we can also give other beta blocking agents in patients with supraventricular arrhythmias. That's why it is not mentioned over here. Migraine is very important clinical indications of beta blocking agents, and remember, it is used for the prophylaxis of migraine, not for the management of migraine. And the exact mechanism is not known, but it has been found that the beta blocker can reduces the blood flow to the brain, and it has direct effect on the cerebral blood vessels, thereby it is useful for the prophylaxis of migraine. And why in hyperthyroidism uh, patients usually complaining of tachycardia or the palpitations. In patients with hyperthyroidism, we can give propranolol to decrease the sympathetic activity that usually occur in patients with hyperthyroidism. And it is also indicated in thyroid storm, that is exaggerated condition, a form of hyperthyroidism. So it is also used in thyroid storm. Now the important points related to the pharmacokinetics, you just need to remember it undergo hepatic force pass effect, and only 25% of the administered drug is available in the blood because of its hepatic force pass effect, number one. And number two, it crosses the blood brain barrier because it is highly lipophilic. Just remember it, propranolol is highly lipophilic, it can easily cross the blood brain barrier. And number two, it undergo force pass effect, and only 25% of the orally administered drug is available in the blood to produce its action. Here you can see there is smolol, that is short acting, nadolol with longer half life. So the shortest acting beta blocking agent is esmolol, and the beta blocking agent which has longer half-life is nadolol. Here you just go through the timolol. Timolol is the beta blocker that is used to treat glaucoma. It reduces the production of aqueous humor in eye and decreases the intraocular pressure. It is particularly useful in the chronic open angle glaucoma. So you just need to remember that Timolol is indicated in patients with glaucoma, and it is also non-selective beta blocker. And we have other agents which can also be used in glaucoma, like betoxazole and cartolol. But remember Timolol. Here you just need to remember the beta 1 selective agents and their importance. The major importance of these beta 1 selective is that they are useful in patients with asthma, hypertensive patients with asthma. They are cardioselective. They don't have effect on bronchi. They do not produce bronchoconstriction. Actually, you just need to go through it. This one, beta 1 selective agents, they have less effect on peripheral vascular beta 2 receptors. Okay, they have more affinity for beta 1 and they have less effect on beta 2 receptors in peripheral vasculature. So they're less likely to cause coldness of extremities. That is a common side effect of beta blocking agents. So this side effect is less frequent with beta 1 selective drugs. Acebutolol and pindolol, which have partial agonist activity, here you just need to remember what is the importance of their partial agonist activity. I am not going to describe as it is mentioned over here. Like you can see these drugs are not pure antagonist. Okay, they have partial agonist activity. Therefore, they weakly stimulate beta 1 and beta 2 receptors. And so where we can utilize this partial agonist activity of these drugs, it is also mentioned over here. You can see they have weak effects in heart rate and cardiac output, and compared to other beta blockers without intrinsic sympathomimetic activity. And you can see they also they're less likely to cause metabolic effects as seen with other non-selective beta blocking agents without intrinsic sympathomimetic activity. So this is the clinical indication of the drugs with intrinsic sympathomimetic activity. So this is their importance. It is effective in hypertensive patients with moderate bradycardia, because a further decrease in heart rate is less pronounced with these agents. Now, labetalol is also quite important. You should know these important pharmacological properties of labetalol. They have affinity for both alpha and beta receptors. So they also going to decrease peripheral vascular resistance by blocking alpha receptors. So they are non-selective alpha and beta receptor blocking agents. They do not alter serum lipids or glucose used in this fourth point is very important. These drugs are used in pregnancy as an alternative to methyl dopa or hydrolazine. In pregnancy, antihypertensive drugs which are indicated in pregnancy are three. One is methyl dopa, second is hydrolazine, and number third one is labetalol. It is usually asked in Viva, can name drugs which are indicated, antihypertensive drugs which are indicated in pregnancy. So these methyl dopa, hydrolazine, and labetalol are indicated, and labetalol is used as an alternative. So the first choice could be methyl dopa or hydrolazine. They produces orthostatic hypotension. As I told you, beta blockers they do not produce orthostatic hypotension, but labetalol produces. Why? Because it also has blocking effect on alpha receptor. And the clinical indication, it is used in hypertensive emergencies. Now, 4 points which are important related to the esmolol. It is a beta 1 selective drug. It is ultra short acting, only 10 minutes duration of action. It is because why? Because it is rapidly metabolized by esterases in the blood, and it is used in supraventricular arrhythmias. So these are the important points related to acebutolol, atenolol, and metoprolol. These are the beta 1 selective. They do not cause bronchoconstriction, and their cardioselectivity is greater at low dose. If the dose is increases, this will going to produce non-selective effect, beta blocking effect. I have already discussed these things. This is I have also done. So these are the clinical indications of beta blockers. Number one is arrhythmias, number two is stable heart failure. You can see which drug is best for arrhythmia, which beta blocking drug is best for the treatment of stable heart failure, and in hypertension we can give propranolol, and which drug is good in MI, myocardial infarction, and which drug is indicated in hyperthyroidism, which drug is good in glaucoma, which drug is used for the prophylaxis of migraine. I think it's propranolol. And beta blockers also used in alcohol withdrawal syndrome, in which the palpitation occur to reduce the sympathetic effects. We can give beta blockers. So these are the adverse effects of beta blocking agents. Remember all of these adverse effects. We can ask you in Viva, and it is all discussed. Last three are the CNS effects of the beta blocking drugs, and the CNS effects especially occur with those which are more lipophilic, that is propranolol. Thank you. Bye bye.